Thank you, ma'am, and thank you, Alok, for this invite. It's a pleasure to be here. So, the instruction course is very well segregated into different segments, and I will try not to intrude on the segments to be covered by others. So, particularly the management part is going to be dealt in detail, both the medical and the surgical management, as well as I think Alok is going to take us through the different tests for dry eye. So, I'll try and stay away from that. What I will do is try and give you a flavor of the different severities of dry eye, the different clinical manifestations of dry eye, mild, moderate, severe. Just a collection of some of the cases that I have been seeing over the past year or so at our hospital. Smrita is one of our fellows who's helped to put together this presentation. So as Alok pointed out, the dry eye definition has been revised. What I would like to draw your attention to is that there is significant discomfort for the patient, and that is why patients come to us. And the other aspect that I would like to draw your attention to in the definition is the inflammation part, because both these things are things which you can see in the clinic, which you can measure, and these are good pointers towards the severity of the condition that we are dealing with. So the more the symptoms, the more the inflammation that we see, the more severe the disease that we are treating it, and therefore the appropriate management would be required. Okay, so this is the Delphi approach to the treatment recommendations. So you may want to score the different manifestations that you see and arrive at a total, and the higher your score, the more severe the dry eye, and therefore more aggressive your treatment. So again, the main parameters here are the discomfort or the severity of the symptoms. So two aspects here: what is the severity of the discomfort and what is the frequency of the discomfort. So as you go from less frequent to more frequent discomfort and a minor degree to a major degree of disabling discomfort, the score increases. The same with visual symptoms. So these are the subjective parameters as reported by the patient, and the rest of it is to an extent objective, things which you see in the clinic, things which you can measure. Things like how much the conjunctiva looks inflamed, whether it is red, how red it is, so you can score that. But again, there could be differences in the way, say, I score this or how Alok scores this. So there is an element of subjectivity to it. There is conjunctival staining, there is corneal staining, and both have individual scores, and there are multiple methods available to score these, standardized. There are the tear film signs, particularly you look at the meniscus, the height of the meniscus, any debris in the meniscus, filamentary keratitis, mucus clumping, and when it gets very severe, you have ulceration on the cornea. The meibomian gland component is always, there's always a component of dysfunction in the meibomian glands, so how severe that is, what is the tear film breakup time, and what is the Schirmer score. So individually, all of these may be variable, all of these may not give you very accurate guidelines, but taken together, they improve your sensitivity and specificity of diagnosis. There are also multiple questionnaires available. One of these is the Ocular Surface Disease Index questionnaire, which has been validated in multiple trials. So you ask a variety of questions to the patient, how they feel about their condition, and then you attach a score to every answer, every response. So you add A, B, and C, the questions that you ask, to get a score which is D. And then you look at the number of questions answered, which is E, and then you compute the OSDI score by multiplying D by 25 and then dividing it by E. So it's assessed on a scale of 0 to 100, with higher scores representing greater disability from normal to severe. So this index also has demonstrated sensitivity and specificity to a great degree in distinguishing between normal patients and patients with dry eye. So although you can do a lot of this in your clinic, and if you are in a setting where you have a specialized ocular surface disease unit or clinic, you may want to use these not just for your patient management, but because you may want to look at your data later for academic purposes and for teaching. So now I'll come to the cases. So what I've tried to do is put the less severe cases at the beginning, and as I move on, I'll go on towards the more severe cases of dry eye that we see in the clinic. So this is a typical case that I'm sure almost all of us encounter in our clinic. Middle-aged female, 47 years old, complains of some blurring of vision, foreign body sensation occasionally. The Schirmer's is lower than 10, so it tells you she does have aqueous deficiency. The visual acuity otherwise is good when you see it in high contrast. though there may be other issues. So we diagnose it as dry eye. You can see that the tear film meniscus is irregular. There is some debris. In this photograph also you can see the punctate lesions on the cornea, the staining, and the breakup time is reduced. So this I would categorize more or less as a mild or a mild to moderate case of dry eye. You do the workup at this age. If you are suspecting some systemic associations, you look for those. Try and rule out any secondary causes of Sjogren's syndrome and manage appropriately. I'm not touching too much about the management because that will be covered later. So after 10 months on lubricants, some topical steroids on and off, and some cyclosporin, the Schirmer has improved a little bit. And after 4 years, you have a value of 28 and 13. The thing with the Schirmer test is it's very variable depending on how you do it. So it's important to standardize the conditions and make sure you do it the same way every time. So in isolation, it may not give you very repeatable values every time. You do it in the morning, you do it in the evening on the same patient, you'll get a lot of variation. Another young to middle-aged lady, 38 years old, who's complaining of redness, itching, a little more severe case. Here you see the staining with both the fluorescein and the rose Bengal. And it's particularly important not to just look at the corneal staining, but also to look at the staining pattern on the conjunctiva, on the bulbous surfaces. So again, a case of aqueous deficiency dry eye, which we manage with copious lubricants. A 34-year-old young man who complained of symptoms only in the left eye after radiotherapy for a nasal malignancy, which was also on the left side. So this is a case of radiation-induced dry eye, something you would see if you're attached to a subspecialty or super specialty hospital. He also has a cataract, which is radiation-induced. So the right eye is absolutely normal with visual acuity and Schirmer. The left eye has severe dry eye, as you can make out with the confluence staining, the SPK, on the corneal as well as the bulbous surface. Same eye down the line. So we treated with a lot of lubricants, tarsorraphy at one point when we wanted to protect the surface for a small epithelial defect. BOSP is the scleral lens, also known as a PROS. This is the scleral lens with an aqueous reservoir, which helps to protect the surface a lot. Some soft steroids and tapering dose, lubricants. And he did well down the line. He's still with us. We've done cataract surgery. He's seeing well, but the eye remains dry. A 36-year-old man who complained of symptoms in both the eyes after bone marrow transplantation. The visual acuity, as you see, is not very good in the right eye because of the irregular surface. The left eye has a small epithelial defect as well as the Schirmer tests are low. So this is a case of graft versus host disease. Again, sometimes condition which can lead to very severe dry eye and very difficult to manage sometimes. So you do whatever you can with the topical medication. You manage the lid margins. Down the line, he developed an ulcer in one of the eye due to secondary infection with healed with the scar. We did a tarsorraphy later because that eye was continuing to have an unstable epithelial surface. And after 2 years, you still see that he has this confluence staining both with the rose Bengal on the conjunctival surface, very visible here, and with the fluorescein on the cornea. So he is using scleral contact lenses in both the eyes, and that is what is keeping him going right now. A 41-year-old female who complains of symptoms in both the eyes for 15 white. She feels much better. She's able to open the eye. The visual acuity is better. And we are strongly suspecting it is a likely case of early OCP, and we posted her for a conjunctival biopsy. So again, I would like to emphasize it is what the patient tells you when they come to you about the severity of their comfort or discomfort, and about both the eyes after consuming rat poison, maybe some medication. History is not very clear. The thing to note here is not just the staining on the corneal and the conjunctival surface, but the lid margin. What you have to look for is that the lid margin, meibomian gland architecture is almost completely distorted, and if you look very carefully, you will see keratinization. That is the keratinized squamous epithelium growing over the mucocutaneous margin onto the conjunctival surface where the conjunctiva should be. So when you see bilateral lid margin keratinization, it is a giveaway both in the upper lids and the lower lid, and this is SJS. So when you see ocular surface disease secondary to SJS, always look for lid margin keratinization. You may not always have frank keratin plaques on the margin, but if you look carefully, the posterior lid margin will be distorted and you'll see an overgrowth of the keratinized epithelium onto the conjunctival surface. So she did very well after a mucous membrane graft in both the eyes to the lid margins. Another young woman, this was a diagnosed definite case of SJS in the acute setting in the ICU, and she came to us later with bilateral dry eyes, and again you see that the lid margin is not as it should be. I don't have a more magnified photo, but here, yeah. So this is day 4 after a mucous membrane graft and 6 months. So the surface remains stable. You can see the lipid keratopathy due to the deep vessels, but with the scleral contact lens, she is maintaining very good acuity in both eyes. And finally, I'll come to this. So you have completely keratinized, I would say dermalized surfaces in both eyes. So you don't need any questionnaire, any grading system, any scoring system for this. You know this is the worst form of dry eye that you and I can deal with. So there's no point treating with lubricants or topical cyclosporin or stuff like that. You just have to do whatever you can. So we did an ocular surface mucous membrane graft, and subsequent to that a keratoprosthesis under it. So that about wraps up my spectrum of manifestations for the severity of dry eye. Thank you.